Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Voles. I want you to imagine you're standing in your kitchen in early January. You just got back from the doctor with your family's health insurance card in your wallet. You've got coverage, employer sponsored. You pay $520 a month for it, $6,240 a year. That's 10% of your family's gross income just for the premiums. And you're about to learn that having insurance and being protected by insurance are two completely different things. Today, we're starting a 3-part series about underinsurance in Southern Oregon. Not the uninsured, we're actually doing pretty well there, with coverage rates above 95%. This is about the 42% of people with commercial insurance whose coverage is so inadequate that they can't actually use it when they need it. That's 13,500 families in our region, 32,100 people. They have insurance cards. They show them at every doctor's visit, and they're not being covered. We're going to follow one family through an entire calendar year. Every cost, every decision, every impossible choice. This isn't a worst-case scenario. This is the median experience for middle-income families in Southern Oregon. And by the end of this episode, you're going to understand exactly how a $7,000 deductible can transform healthcare into a financial crisis. Let me introduce you to this family. They live in Medford. 2 parents, 2 kids, age 7 and 11. Combined household income, $62,000 a year. One parent works construction supervision, the other works for a nonprofit. They're not struggling, they're not poor. By Southern Oregon standards, they're doing okay. They're at the 103rd percentile of median household income in Jackson County. They rent a house for $1,450 a month. They've been saving for a down payment to buy. They've got $16,500 in an emergency fund, which is actually quite good. The median emergency savings for their income bracket around here is only $4,200. They have employer-sponsored health insurance through the construction firm. 85 employees. Here's what that insurance looks like. Monthly premium, just the employee's share, $520. That's $6,240 a year, or 10.1% of their gross income before they've seen a doctor even once. Annual family deductible, $7,000. That's 11.3% of their gross income. After they hit that $7,000 deductible, they still pay 20% coinsurance on everything until they hit their out-of-pocket maximum of $14,000. Think about that. If this family has a bad health year, not catastrophic, just bad, they could spend $14,000 out of pocket, plus the $6,240 in premiums. That's $20,240, or 32.6% of their gross income. Now, you might be thinking, that's a bad plan. They should get better insurance. Here's the thing. This is the only plan their employer offers, and it's not unusual. In a survey we did of 127 employers in Southern Oregon, 64% offer plans with $6,000 to $8,000 family deductibles. 71% have employee premium contributions between $450 and $600 a month. Could they buy insurance on the individual market instead? At $62,000 for a family of 4, they're at 266% of the federal poverty level. That means exactly 0 premium tax credits. Individual market plans would cost them $1,680 to $1,950 a month in premiums, triple what they're paying now for similar or worse coverage. Could they get on Medicaid? Nope. Oregon Medicaid eligibility for a family of 4 ends at $43,056 annually. They earn too much. They have insurance. They have no better options. So let's see what happens when they try to use it. It's early January. One of the parents, the construction supervisor, has a slipped disc in his neck. It's been diagnosed for 4 years. It's managed with occasional physical therapy and anti-inflammatory medication. It doesn't prevent work, it just requires periodic intervention. In early January, it flares up, pain radiating into the shoulder and arm. Sleep is disrupted. Overhead work tasks become difficult. The clinical recommendation would be straightforward. Primary care visit, updated imaging to assess progression, physical therapy if indicated. Here's the financial calculation they're doing instead. Primary care visit, $185, applied to deductible. Cervical MRI if ordered, $1,620, applied to deductible. Physical therapy, $165 per visit, typically twice a week for 6 to 8 weeks. That's 12 to 16 visits, or $1,980 to $2,640. Total projected cost before insurance contributes a single dollar, $3,785 to $4,445. And this is happening in January, when property taxes are due. When heating oil costs peak at $340 to $420 a month instead of the summer rate of $120 to $180. When holiday credit card bills are arriving. When they've made exactly zero progress toward that $7,000 deductible. So they make a decision: delay care. Take over-the-counter pain relievers, hope it resolves. This is cost-based healthcare rationing, and it's not irrational. It's completely rational given the math they're facing. In our survey of 2,847 Southern Oregon families with employer coverage, 67% reported delaying care in January through March, specifically because of the deductible reset. 43% delayed treatment for chronic conditions, 28% delayed care they later described as probably necessary at the time. The construction supervisor uses over-the-counter medication, applies heat, modifies work techniques to avoid overhead tasks, and hopes for improvement. Here's what happens next. The pain doesn't resolve. By mid-February, sleep deprivation is affecting concentration. At work, there's a minor error, misreading measurement specifications. Material has to be reordered. Project gets delayed by 3 days. Cost to the employer, $840. Now nobody connects that error to untreated neck pain. It doesn't show up in the health plan reporting. It's not on any invoice. But it's real. It happened. And it's a direct consequence of benefit design that makes clinically appropriate care financially prohibitive in the first quarter of the year. We're going to come back to these hidden employer costs in a later episode. For now, just tuck this away. The $185 primary care visit that didn't happen in January just cost the employer $840 in February, plus 3 days of project delay, plus customer relationship management. But we're not done with this family's year yet. Not even close. Segment 4. March, the pediatric mystery. Early March. The younger child, age 7, develops recurring abdominal pain. It's not severe, but it's concerning. They take the child to the pediatrician. Office visit, $180. Laboratory work, CBC, comprehensive metabolic panel, stool studies, $420. Follow-up call to discuss results. No additional charge. The results are normal. The pain resolves within 10 days. The child is fine, which is obviously the most important thing. Total cost, $600. They've now spent $600 toward their $7,000 deductible. Only $6,400 to go before insurance starts helping. But here's what that $600 represents to this family. 42% of their monthly take-home pay, the equivalent of 2 to 3 weeks of groceries. The outcome is reassuring. The child is fine, but the family is $600 poorer for that reassurance. And this is the moment. We saw this over and over in our research. This is when families start to associate medical care, even appropriate and reassuring medical care, with financial penalty. In our behavioral research with Southern Oregon families, 71% reported that accumulating costs for normal health care created anxiety about seeking future care. 54% said it made them resent their health insurance despite being glad to have coverage. 38% said it created family conflict about when medical care was really necessary versus probably fine to wait. This is not about catastrophic illness. This is about how insurance design transforms routine pediatric care into a source of household financial stress and healthcare avoidance. By late April, several things happen. The construction supervisor Skips recommended follow-up care. The neck pain hasn't resolved, but it's plateaued at a manageable level with over-the-counter medication and work modifications. The internal calculation is, if it gets significantly worse, we'll deal with it then. This isn't denial. This is budgeting. Both children have their annual well-child visits in May. These are covered at 100% under ACA preventive care requirements, so no cost there. But the pediatrician recommends vision screening for the 11-year-old due to reported headaches and classroom squinting. Vision exam, $125, applied to deductible. Glasses if needed, $280 to $420, not covered by medical plan. They schedule the vision exam but delay purchasing the glasses until we see how the year goes. Summer camp registration for the 11-year-old includes a required sports physical, $145, applied to deductible. They choose a non-sports camp to avoid the physical. By the end of May, cumulative deductible spending, $870. Deferred care, neck pain management, vision correction, sports physical, household financial anxiety, measurably elevated. This is the experience of the insured, not the absence of coverage, but the inadequacy of coverage to make care financially accessible. The family is now operating in permanent defensive mode. Conversations about health care have shifted from what do we need to what can we avoid? And we're only 5 months into the year. June 8th, school field day. The 11-year-old falls during a relay race. Immediate visible swelling to the left wrist, pain with movement. Decision point: emergency department or urgent care. Emergency department would cost $2,950 to $3,820. Urgent care would cost $755. They choose urgent care. This is the financially rational choice, but it requires healthcare literacy that not all families possess. 23% of families in our survey said they would have gone to the ED because that's where you go for broken bones. X-rays confirm a distal radius fracture. Splint applied. Orthopedic follow-up recommended within 3 to 5 days. Subsequent costs: urgent care visit, $755. Orthopedic consultation, $350. Casting and immobilization, $280. Follow-up imaging at 4 weeks, $380. Cast removal and final check at 8 weeks, $185. Total fracture-related costs, $1,950. Cumulative deductible progress by end of June, $2,820 of $7,000. That's 40.3%. The child heals normally. The fracture is uncomplicated. This is exactly what insurance should cover. But the family has now spent $2,820 in 6 months for delayed neck care that still hasn't been addressed. Reassurance about abdominal pain, that was fine. A fractured wrist from a normal childhood activity. None of this is unusual. None of it is preventable. All of it is expensive. And they're still $4,180 away from their insurance actually starting to help in a meaningful way. July and August should be relatively calm, healthcare-wise. Kids are out of school, reducing illness exposure. Weather is good. Outdoor activity is high. But the family's relationship with healthcare has fundamentally shifted. What they avoid. Summer camps requiring medical clearance visits, $145 per child. Elective procedures. The 7-year-old has a small hernia that could be surgically corrected but is asymptomatic. Surgical costs would be $8,000 to $12,000 even after insurance contributes. They continue monitoring instead. Preventive dental beyond basic cleaning. Orthodontic evaluation recommended for the 11-year-old, but that's $275 for the consult and not covered by their limited dental plan. The construction supervisor continues avoiding neck pain treatment despite persistent symptoms. In our qualitative interviews with Southern Oregon families navigating similar situations, we heard these themes over and over. We feel like we're one accident away from financial disaster, even though we have insurance. I spend more time thinking about whether we can afford to go to the doctor than whether we need to go to the doctor. Having insurance feels like having a parachute that only opens after you've already hit the ground. This is not about lacking coverage. This is about coverage that fails to provide financial security, which is supposed to be the whole point of insurance. So, here we are. It's the end of August. This family has insurance. They've paid $5,720 in premiums so far this year. That's 8 months at $520 per month, plus whatever their employer contributed that they never see. They've spent $2,820 out of pocket on care. They're still $4,180 away from hitting their deductible. Early September. The construction supervisor's neck pain has significantly worsened over the summer. Sleep is now severely disrupted, waking 4 to 6 times per night. Arm numbness is occurring, and work performance is measurably declining. 2 additional errors in August, both requiring rework and material replacement. The supervisor's employer notices. There's a check-in meeting. The message is supportive but clear. We know you're dealing with something. We need you at 100%. What can we do to help? And the supervisor recognizes something. Delaying care further risks employment. This is the moment when healthcare avoidance ends, not because symptoms have become unbearable, though they have, but because job security is threatened. So care finally gets accessed. Primary care visit, $185. Cervical MRI, $1,620. Orthopedic consultation, $420. Physical therapy, 12 visits over 6 weeks at $165 per visit. That's $1,980. Add it all up, $4,205 in September alone. The deductible is met, finally, in month 9 of the year. And here's what a lot of people don't understand about how these high deductible plans work. Meeting the deductible doesn't mean you stop paying. It means insurance starts paying 80%. You're still on the hook for 20% of everything until you hit your out-of-pocket maximum. For this family, that maximum is $14,000. Physical therapy continues through October, but now insurance is paying 80%, right? So the family pays $264. Okay, that's manageable compared to paying everything, except the physical therapy isn't providing sufficient relief. In late October, the orthopedist recommends an epidural steroid injection, which costs the family $568. They've now spent nearly $8,000 out of pocket on healthcare, plus the $5,720 they've paid in premiums through October. Total healthcare spending through October, $13,577. Let me put that in context. This family's gross household income is $62,000 annually. Healthcare spending so far, $13,577, or 21.9% of their gross income. For comparison, they spend 28.1% of income on rent. They spend 15% on food. They spend 12% on transportation. Healthcare is now their second largest household expense, and it's closing in on housing. And we still have 2 months left in the year. Let's look at the complete picture of this family's finances by the end of October. Monthly take-home pay after taxes and mandatory deductions, $4,022. Total fixed expenses, $2,845 per month. Remaining for everything else, $1,177 per month. The budget doesn't work. It mathematically doesn't work. So what have they done to make it work? Financial coping mechanisms deployed. Savings depletion, emergency fund reduced from $16,500 to $8,900. They've burned through $7,600 of their emergency savings. Credit card debt increased from $2,100 to $6,340, an additional $4,240 in debt accumulated. Deferred maintenance, vehicle registration renewal delayed, home maintenance projects postponed, reduced spending, food budget cut by $140 per month. That's buying cheaper food, fewer fresh fruits and vegetables, more processed items. Children's activities reduced, no discretionary purchases. Let me tell you what this looks like in terms of validated stress assessment instruments. Financial stress, severe range, 89th percentile for their income bracket. Healthcare-related anxiety, clinically significant, 76th percentile. Relationship conflict, moderate increase. Arguments about medical spending, future healthcare decisions, budget trade-offs, work performance, self-reported decline due to stress and sleep disruption. This family did not experience catastrophic illness. They did not overuse care. They did not lack insurance. They experienced a normal health year. Now let's compare this to other places. Medford healthcare spending, $15,862, or 25.6% of gross income. Portland Metro, same income, same health events, $11,640, or 18.8% of income. Eugene, same income, same health events, $12,580, or 20.3% of income. National average, same income, same health events, $12,180 or 19.6% of income. Southern Oregon, premium $3,222 to $4,682 more per year than comparable markets. That's 21 to 37% higher. The difference is not their behavior. The difference is regional market structure. Here's something ironic that happens in November. By now, the family's cost sharing is actually more favorable than it's been all year. The deductible is met. Coinsurance is only 20%. Many services are now substantially more affordable than they were back in January. But the family avoids care anyway. Why? First, financial exhaustion. They've spent over $8,000 out of pocket. Their emergency fund is depleted. Their credit card debt has tripled. They're in financial survival mode. Second, timing awareness. It's November. In January, the deductible resets to $7,000. Any care they access now will be followed in 8 weeks by a return to paying full freight for everything. The family has the best cost sharing they've had all year. But rational financial decision making leads them to avoid care that might actually help. This is not a failure of the patient. This is a failure of insurance design. Mid-December. The renewal notice arrives from the construction firm's HR department. 2025 plan changes. Monthly premium, employee share, increasing from $520 to $578. That's an 11.2% increase. Family deductible, unchanged at $7,000. The employer's message: we fought hard to keep the deductible flat. The carrier wanted to increase it to $7,800. We absorbed some of the cost increase through higher employer contributions, but we had to pass some along to employees. Their income increased 3% from 2023 to 2024. Healthcare costs just increased 11.2%. Over time, this gap is unsustainable. So let me tell you how common this story is. This family is not exceptional. They're representative. In Southern Oregon, 42% of people with commercial insurance meet the clinical definition of underinsurance. That's out-of-pocket costs exceeding 10% of household income, or deductibles exceeding 5% of income. For this family, both are true. Here's the breakdown by income bracket in our region. Families earning $40,000 to $60,000. 64% are underinsured. Families earning $60,000 to $75,000. 51% are underinsured. Families earning $75,000 to $100,000. 38% are underinsured. These aren't outliers. These are medians. Families like this one have insurance. They're doing what they're supposed to do. They show up to work. They pay their premiums. They're trying to make responsible healthcare decisions. The system is failing them. Next episode, we're going to zoom out. We're going to look at what this pattern means for the entire region. What happens to our schools when families leave Southern Oregon because they can't afford to stay? And we're going to start talking about why this is happening. The market structure that makes Southern Oregon healthcare costs 21 to 37% higher than comparable markets. The carrier concentration, the provider consolidation, the policy gaps. Because understanding the why is the first step toward fixing it. This family's story isn't over. We're going to follow them forward into the 3 possible futures they face. The status quo, where things get worse, modest intervention where they improve a little, or comprehensive regional solutions where this becomes sustainable. But before we can get to solutions, you need to understand the full scale of the problem. That's next time. This podcast is for educational purposes only. I might get details wrong. If you catch errors or have alternative perspectives, please comment. Subscribe to our newsletter at reimagine-healthcare.org. Thanks for listening.